tilted, sir, volarly.
So what do you think on this lateral radiograph? What is your impression?
Sir, it's I think the VISI, sir,
Okay,
volar
so
deformity, sir.
what made you think this is VISL?
Sir, because there is the volar, not the volar actually. This is the dorsal tilted lunate, sir, and there is increased scapholunate angle, sir.
So scapholunate angle is increased, that you are right, but how does this make VC deformity?
Oh,
What is
sir,
the
not
normal
sure, not sure,
scapholunate
sir.
angle? Okay, that's fine. Do you know the normal scapholunate angle?
No, sir, forgot it.
Okay, so do you know what is DC and VC deformity?
Sir, in the VC deformity, the scapholunate ligament is torn, sir, and the lunate is subluxed volarly, sir. And in the DC, sir, the lunotricutal ligament is damaged, sir, and scaphoid and lunate both are tilted dorsally, sir.
What are the ligaments involved?
Scapholunate ligament, sir, and lunotricutal in the other ones.
Okay, so which ligament is involved in DC deformity?
Lunotricutal, sir.
Right. So, Shafkat, I think you need to revise this topic. So I'll stop here
Yeah.
and we'll give the feedback, if that's all right.
Yes, sir. Yes.
So I'll start with the feedback of this case and then the previous, and then we will go. So I just want to make this concept clear to everyone. So DC and VC deformity is a bit complex. This is a scaphoid unit, and there are dorsal ligaments, and there are ligaments between lunotriquetral. In DC deformity, scapholunate ligament is disrupted. So when this ligament disrupted, lunate and triquetral, they stay as one bone, but scaphoid flexes forward. So this is a DC deformity, and scapholunate angle increases from 70 degrees, 90 degree at the moment. So in DC, lunotriquetral is intact, scapholunate is gone, so scaphoid flexes forward. But when there is VC deformity, the scapholunate is intact, lunotriquetral is gone, and scapholunate moves as one unit. So the scapholunate angle is decreased. This station is important because in CPSP talks, they have tested it 2 to 3 times. Even in my talks, they showed me 3 pictures of scapholunate angle, one normal, one DC, one VC, and asked me to draw the angles. So you can say this is scaphoid, you can see. So one line is drawn along the scaphoid, and this one is lunate. So one line you need to draw along this axis. So this will give you the angle of scapholunate. Did you understand it?
Yes, sir.
All right. So you need to read this before going for the exam. All right.
Yeah.
So Shafkat, whenever you look for the case, I was expecting on the AP radiograph that you will mention the Terry Thomas sign. This is a Terry Thomas sign. I would say, looking at this X-ray, this is an PA radiograph of the wrist. The most obvious finding is increased scapholunate distance. Although I would like to compare it to the other wrist, and I can see some. Increased scapholunate distance. That's why I want to see the lateral radiograph. I can see increased scapholunate angle, and this confirms my diagnosis of DC deformity. DC deformity, then he will ask you questions about DC, what happens, what is the pathophysiology, and then what is the management. So the management will be acute and definitive. We need to do the MRI in this case as well if we are going for some definitive planning. In the key, there was also a question about slack scapholunate advanced collapse and its stages. You need to remember those stages as well. There are 3 stages of slack deformity. So you need to remember that. Regarding your first case, I think you did very well. I didn't have any more questions for you. So you did very well. So I will ask Heather, please, to go for the short case.
Hello.
Can you please see this video? Can you see the video?
Yes, sir. Yes, sir.
Okay,
Yeah,
Heather will
can you
take
please
over.
describe it? Yeah. Can you please describe this video? Yeah.
Uh, sir, this is uh, the crouch gate, we can say, the spastic crouch gate, sir.
Okay. Okay. So what are the components of the crouch gait?
Sir, there is a flexion at the hip, sir, and there is the flexion at the knee joint, and the heel is in equinus, sir. And patient,
Uh, is the heel in equinus in crouch gait?
no, sir, not heel. Heel is fine, sir.
Okay. So what's the position of a heel normally in the crouch gait?
Uh, heel, uh, heel touches the ground, sir. It's on the ground, sir.
Okay. So how will you examine a patient with a CP, cerebral palsy,
Okay, sir.
after the gait?
Okay. I will start with the introduction, then I will ask आपको ये मसला कब से है बच्चे को और पैदाइशी है या बाद में कितने अरसे बाद हुआ है and then
Yep.
the gate and then get the gate after gate I will sit patient ask the patient to sit and then check the reflexes and then check the tripod sign. Then I will ask the patient to lie down, sir. Then I will check the uh, ankle clonus and Babinski sign, and then I will check the popliteal angle and then check the hip adduction and uh,
Okay. What will you see on the ankle? What will you examine over the ankle joint?
sir, on ankle joint, the ankle reflex, clonus, Babinski, and then the dorsiflexion of the ankle, and then the silver square test, sir.
Yeah. So can you the silver square test? How will you interpret
Okay.
it?
Sir, I will check the dorsiflexion by putting the palm on patient heel. Then I will the knee is in the extension. Then I will check the dorsiflexion and then keeping pressure on the foot, I will flex the knee. If the dorsiflexion increases on knee flexion, then this is the positive silver square, and it means there is the contracture of the gastrocnemius is more.
Okay. And what will you examine over the knee joint?
Sir, on the knee joint, I will check the uh, flexion contracture and then the popliteal angle and knee reflexes and flip
How do you
gracilis
make the
sign.
popliteal angle?
Sir, I will flex the hip to 90 degrees, sir, and then I will maximally extend the knee and then I will measure with the goniometer.
Okay. So which angle will you measure between?
The lack of extension actually the how much it is there, sir.
It's between the vertical distance between vertical
Yes,
and
sir.
the line across the.
Yes,
Yeah.
sir, sir.
And what else in the hip? Any
Uh,
specific test in the hip you would like to do?
Sir, hip flexion contracture with the Thomas test, sir, and then the adduction contracture, and by excluding the gracilis, then check the adduction again, sir.
Okay. Will you explain the Thomas to me, please?
Sir, I will. Patient is lying flat and preferably on the hard couch, sir. And I will put my palm under the patient lumbar vertebra, sir. And then I will flex the opposite leg till the time that lumbar lordosis is finished and the lumbar vertebra is touching my hand. And then I will check the flexion contracture on my side of the hip, sir.
Okay. I think it's a long examination with the CP. So can we move on the types, like what types of the CP are there?
Sir, there are the spastic, sir, and then the ethetoid and the mixed. In the spastic, we can the other according to the patient, the anatomical classification will be the monoplegic, diplegic, or hemiplegic or quadriplegic, sir.
Okay. So we can describe it as anatomic or physiological. And how do you classify it? Like the ambulatory status of the patient?
Sir, this is a GMFCS stages, sir, and in the stage 1, the patient is ambulatory without any support. He is community ambulator, and in
Time
stage 2,
Okay. Okay. So should we do the next one now?
Yes, please.
Okay. Is this a video or just a picture?
Picture and then.
Okay. So can you please tell me what the examiner is trying to examine over here?
sir, the examiner is checking the teres minus external rotator of the shoulder, sir.
Okay. So okay. So will you take me through the examination of the shoulder? Like it's a part of the
Sir.
rotator cuff, yeah.
Sir.
So
Sir, first of all, introduction. I will introduce myself, then get permission, then asking आपको क्या मसला है और कब से है, and if there is any other question I can ask, then
the patient
inspection
says
from the
that
front.
the patient says he's unable to abduct his arm beyond 90 degrees.
Sir. And then inspection from the front, basically any wasting, scar mark, or any discharging signs. Then position of the arm, and then from the side, usually the elbow attitude and the wasting of deltoid. Then from the back, the cervical spine, and then the position of the scapula, symmetrical wasting of supraspinatus or infraspinatus area, and then temperature will just compare. Then tenderness in the sternoclavicular joint, clavicle,
We'll just
acromioclavicular
make it
joint.
short. Yeah. I think we are short of time. So how will you check the rotator cuff muscles here? in this
Okay, sir.
patient?
I'll try abduction, initial abduction by 0 to 30 degree from supraspinatus, and then belly press or lift off test for subscapularis.
So for the supraspinatus, in which plane you will do the abduction?
In scapular plane, that is 30 degree forward, sir, as from the patient body, sir, scapular plane.
Okay. And you will resist against the patient?
Yes, sir. Compare bilateral.
Okay. Next, what else?
Then the belly press test or lift off. If the patient can do internal rotation, then lift off test, and if cannot, then belly press test. We'll compare opposite side.
How will you do the belly press test?
I will ask the patient to press on his belly, and I will put my hand. I will check the resistance, how much is giving.
What will be the position of elbow while doing the belly press?
It's 90 degree flexion, sir.
And where it should be? Should it be behind the axis of the body or front?
It will be front, sir.
It will be front. Okay. And next after this?
After this, the test that is being shown in this picture, external rotation while knee flexion, elbow flexion, checking the external rotation, sir.
Okay. So you have completed your examination and you feel there is a deficient
I will just check the
function.
range of motion as well, sir. Passive and active.
Yeah. Okay. So
axillary nerve and Baton score, sir.
Good. And you found the deficient function of the supraspinatus. How will you proceed further then?
I will ask the detailed history, the duration, then the hand dominance, and the any pain, and what is the patient age and his occupation, and then I will proceed with the I can have the X-ray of shoulder AP view, and after that I will request for MRI right shoulder, sir.
What will you like
sir,
to see on X-ray?
Sir, there will be the acromiohumeral distance, sir, and then the joint space, glenohumeral joint space, sir.
Okay. And what will you like to see on MRI?
MRI, sir, I will like to see the rotator cuff continuity, then the labral continuity, and if any bone loss in the humerus or the glenoid, if it is there.
Time's up. Feedback.
Okay. Yeah. Should we go to the first one? Yeah, CP. Yeah, it was good. You know about the. I think the in crouch gait, the ankle goes in dorsiflexion as well. So you're seeing it as equinus. And other than that, it's a lengthy examination, obviously. And you did well. You know about the silver skyole, popliteal angle, Thomas. You did well. You knew about the classification as well. And although we couldn't have time to discuss the management, but regarding the number of questions, you did well in all of the questions. Yeah, that was good. It's difficult to cover CP in 5 minutes. And regarding the shoulder again, yeah, mm, you were good. And if it's a short case, then we need to be quick, and we need to focus on the important aspects. Like in the rotator cuff, we can't complete the examination without the function of the muscles. So we in the very beginning, we start with the range of movement active. And if the patient is unable to complete any active movement, then we do it passive. It will help us differentiate between whether it's a frozen shoulder or it's a rotator cuff issue. In a frozen shoulder, even on the passive movement, you'll be unable to complete the movement. And while in rotator cuff on passive movement, you should be able to do the range of movement. And the test, you had good idea about how to perform the test and what's the position of the hands. Just try to explain the each test. Just taking name of the test isn't sufficient. You should be able to exactly describe what will be the position of the patient, what will be the position of you, where you will hand, what the exact moment you will like to do. And yeah, on prompting, I had to prompt, but you had an idea that how will you perform this test. And you described the X-ray well, like on the X-ray, we need to see the rotator cuff orthopathy, like the proximal migration associated with arthritis. And you had an idea on this as well. And on MRI, I would like to listen about some specific signs like tangent sign, any retraction of the cuff muscles medial to the glenoid, or the percentage of the uh, cuff tear and any fatty infiltration. Although I believe you must know all of these, although you didn't have time to describe these things. So overall, yeah, it was good. You had a good flow. So yeah, I think
Thank
we
you,
can
Heather.
finish.
Thank you so much, sir. Thank you so much, sir,
Shafkat,
for
just one thing to add. I mean, you know the stuff, but things get slightly uncomfortable if you are doing a rotator cuff and you say beaten score. I also mentioned that I know you all have reviewed the surviving book, but the key is just for the guide. You have to tailor the examination yourself to make sure you are a good clinician. If you ask beaten score in a rotator cuff patient, then it will not give a good impression. So tailor the scheme, act like a clinician as the patient is in your clinic and you are going to give treatment.
sir.
Thank you so much. So
Thank you so much, sir. Thank you, sir.
next patient is, oh, sorry, next candidate is, can you unmute yourself, Salman? And your examiner is, so I'm your examiner now. All right, I think Salman will be taking short cases. Is that all right,
Yes,
Salman? I think we have just changed it.
yes, sir. Can you hear me?
Yeah, yeah. All right. So, Salman, candidate Salman, this is a 35-year-old patient presented to you in A&E after an injury. What can you see on the X-rays?
So this is an X-ray of a skeletally
Can you please
mature patient.
speak loud? We can't hear you.
So this is an X-ray of a skeletally mature patient. Lateral view. Uh, the site is documented, and the name of the patient is also documented. The most obvious finding, it is centered on the elbow joint, showing the distal humerus and proximal radius ulna. The most obvious finding is that there is a posterior dislocation and a radial head fracture. And I can also appreciate a small chip on the anterior aspect, which might be a coronoid.
All right. So, what do you want to see?
Sir, I want to see the AP view.
All right. AP view didn't add much information. Patient is in front of you in A&E. How will you manage the patient?
Uh, Starting with the short history in the accident and emergency, I will start with the ATLS protocol. After checking for the ATLS protocol, I will try to reduce the elbow joint in sedation. And before reducing, I want to check the distal neurovascular status, any skin, bleeds, abrasions, or lacerations.
All right, so
Or
this is a closed fracture, neurovascularly intact. And what is your management now?
starting with the starting after completing the ATLS protocol, I will try to reduce the fracture and see the distal neurovascular and apply the back flap.
All right, so you have reduced the elbow. The X-ray show the elbow is reduced with fracture of the radial head and coronoid process. What is this injury basically called?
So this is a terrible triad of the elbow.
All right. So in terrible triad, do you know the sequence of injuries? If I talk about old risk call sequence of injuries, do you know about that?
Yes, I just forgot. It's mm, first of all, there is a medial collateral ligament injury, lateral collateral ligament injury, elbow dislocation, and sorry, for that.
All right, that's fine. So what is your next plan now? Elbow is reduced, patient is in back flap. What is your next plan now?
So my next plan is to admit the patient and counsel the patient about the severity of the fracture.
Okay,
And
he says okay, do whatever you want. So what will you do next?
okay, so then I will send some baseline investigation for anesthesia and take the anesthesia fitness of the patient and plan the
So
surgery
he's
on.
asking what is the procedure? You have taken the consent. What is the procedure you are going to do?
So uh, I will tell the patient about the surgical procedure, which would be open reduction in internal fixation.
Okay, so
And
what are you going to do? Can you tell me? I'm your assistant in the theater, and patient is on table. What are you going to do for this patient?
so first of all, I will put the patient in spine position with a side tray and check for the inventory. Uh, After checking the inventory, I would ask my assistant to put on the tourniquet
No,
above the
so
elbow.
that's fine. That's fine. That's good. Just the last question. What will you do for this patient? What will you fix?
So,
What is your sequence of
uh,
fixation?
I will start with the Copper's approach from the lateral side, and
Good.
first of all, I will fix the
All right.
first.
So let's go to the
I check.
next case. I'll come back. So Salman, this is the 70-year-old patient presented to you in A&E after a high velocity injury. What can you see on the X-rays?
So this is an X-ray of a skeletally mature patient, AP and lateral view centered on the knee. The most obvious finding which I can appreciate is that there is a posterior dislocation of the knee joint.
All right. So the patient is in front of you. What are your concerns?
So as this is a high velocity injury and I would start with the ATLS protocol and check for the ABCDE. And after stabilizing the patient, I will send the patient for a radiograph. And, as this is a radiograph, I can appreciate the knee joint. So my concerns are for this patient is that the neurovascular status and compartment of of the
Or
patient
all right.
leg
What
and
are the right? What is the classification for knee dislocation?
the knee dislocation classification is KD classification. In in KD classification, this is type 2.
That's fine. I want to know the classification. What is the classification?
Mm, sorry, sir, I forgot.
That's fine. Okay. So this patient on clinical examination has reduced pulses. So what will you do now?
So I will take the patient to the OR and in sedation I will try to reduce the knee, the closed knee.
Okay, the knee has come back, but the pulses are still not coming back.
Then I will wait for some time and put the patient in the splint. And if
Okay.
after few few minutes the pulses are not palpable, then I will go for the CT angiogram.
CT angiogram. So CT angio confirmed that there is a vascular injury. What are you going to do?
If there is a vascular injury, then I will take the help of a vascular surgeon and do the open exploration of the vessel in the OR.
Okay, just the last question. What is the sequence of events of surgery with a vascular injury with vascular surgeon?
First of all, I will stabilize the knee by the external fixator, then exploration of the vessel and repair. And after exploration, I will do the fasciotomy of the leg compartment. And in the end, I will do the aseptic dressing.
All right. When will you apply the fixator?
So before repairing the vessel.
Okay, that's fine. Thank you. So just a quick feedback for the first case. I think you need to study the terrible triad. Terrible triad. So I will describe this that this is a lateral radiograph with obvious finding of posterior dislocation and there is radial head and coronoid fracture. I'm concerned about the soft tissue because I'm not sure what's going on here. I will like to see the AP radiographs and management would be I will assess the patient and my concerns are open fracture and neurovascular injury. You said very well about ATLS. That's very good. And then I will go ahead and after neurovascular examination, you didn't mention about CT scan before going for the surgery. I mean, think step by step. After X-ray, you will go CT because in radial head, you are going to decide whether you are going to to do the arthroplasty or you are going to repair, fix the radial head. And so you need to think about CT scan. Do not jump on surgery unless you have done complete workup. Because if you, that's why I think you were struggling when I was asking you what you will do. And also study the old risk call sequence. So it starts lateral, uh, anterior, posterior, and then medial. And then you need to know the sequence that you are going to fix these. So you fix the medial collateral at the end after checking for stability. So all of you, please
Yes.
read the terrible triad and Oris call. About the knee dislocation, I think you described it very well. And then about the management, I think you need to be more careful because if the pulse is not coming, you didn't mention ankle brachial pressure index. That is very important. And unless you mention ankle brachial pressure index, the examination is not completed for a knee dislocation. So for knee dislocation, you need to know the classification. You need to know a few things like irreducible dislocation. You need to know the sequence of events. You need to know the examination. ABPI is very important. You can mention Doppler, but ABPI is gold standard. And then comes the CT angiogram is the gold standard as well. And then the sequence of events is I mentioned in the group as well and in my new MCQ book as well, there are three scenarios that I have discussed that what you do, first of all, you do the vascular shunt, then you apply the fixator, then you do the vascular repair, and then you do the fasciotomies because vascular injury has a 6 hours window. After that, you might end up in amputation. So shunting means you do a primary revascularization. All right.
Okay.
So Salman, please, can you take the first short case? Yeah.
Yeah, Salman, can you hear me?
Yes, sir.
Okay. So
Okay.
So this is a 30-year-old patient who has come to your clinic. He had a pop while playing a football. Irfan, can you please show the X-ray?
Yeah.
So, can you describe the X-ray for me quickly?
Yes, sir, this is a radiograph of a skeletally mature patient showing the AP view of a knee joint. The most obvious finding is that which I can appreciate that there is a chip fracture of the lateral proximal tibia. Probably this is a second fracture.
Second
And
fracture. Okay, good.
keeping in
So
mind the
how will you
history,
examine this patient?
sir, I will start with the inspection. On inspection, from the front, I will see the wasting and attitude of the knee, quadriceps wasting and attitude of the knee, and from the front, I will see the any flexion, contraction from the behind. I will see the popliteal fullness, and after inspection, I would like to see the gait of the patient, and then I will go for the palpation. Palpation temperature will be okay. Tenderness on the lateral aspect, and all the bony prominences,
Okay.
pulses. Sensation is not uh, that much important, so I will skip that and I will instead go for the special test.
Okay. What are the special tests you are going to do? Can you please
The
first name the scheme? Tell me this. Tell me your scheme. And then we'll go through the test.
So my theme will be starting with the varus valgus stress test in flexion and 30-degree flexion and extension, and
Okay.
after that I will do the Leishman test and check for the patella gliding, patellar instability, and this will be after
Any other specific test that you would like to do based on the imaging that you have seen?
flex the knee and do the anterior draw and posterior draw and slocum test. After slocum, I will check the Gardner test for posterior side.
Sorry, say it again.
After doing the anterior and posterior draw, I will check the posterior side in extension in 90-degree flex.
Okay. So how will you do the Lachman test?
Position. And on the other hand, I will grab the proximal tibia and do the anterior and posterior blockment of the tibia, translation of the tibia on the knee.
Okay. So you have done the examination. So it confirms. What is your suspicion on
Something,
based on this X-ray? What will be the injury?
can I add something in examination?
Yeah, sure.
Sir, I forgot to do the McMurray test for medial and lateral minute.
Okay,
So
good.
I will.
What else? So what is your impression based on this X-ray? What injury this patient could possibly have?
Sir, as this is a second fracture which is associated with the ACL TS.
Okay, good. So this is an ACL injury. Then how will you further investigate this patient?
So after taking an detailed history examination, I will order the X-ray as this is the X-ray. So my suspicion of the ACL tear is.
You have done the X-rays. Come out of the X-ray.
Now I will order the MRI.
MRI. Okay, so you have got the picture of the MRI. Can you see anything? Can you describe
Yes,
the MRI?
yes, sir, this is the T2 weighted images, vital images. It is on the lateral side as there is a hockey shaped tibia, and
Okay.
on there is a discontinuity of the fibers of the. It's not a discontinuity. It is a some fiber hyper intense. Not a
Okay. So
might be a
the
great.
patient is a 30-year. He's a sports player. How will you proceed?
Yes.
So this is a fresh injury. Remember.
Okay.
How
So
will you
first of
manage
all,
this patient?
so, this is a fresh injury, so I will check the patient for the other injury, distal neurovascular status.
There is no other
in
injury. This is an isolated injury.
this is an isolated injury, so I will prescribe the patient for knee mobilizer, painkiller, and follow up in OPD after 2 weeks,
Okay, the patient has
so
come
that
back
the
after 2
edema
weeks.
and the pain
What will
will be
you do?
settled.
So pain has
So now
settled.
I will
Now, what will you do?
now I will examine the patient
Mhm.
for
Examination findings
injuries.
are same. He has a Lachman and anterior draw positive.
Okay, so now I will start the rehabilitation uh, uh, to strengthen the quadriceps and
Okay.
achieve the
Good.
knee
You have
strength.
done the rehab that the patient has the range of movement has increased, but he think that his knee gives way. His knee is unstable.
Now I will sit the patient with the patient and counsel him for the ACL reconstruction, as he is a sports
Okay.
person. So
Okay. ACL reconstruction. Good. How will you do it?
uh, I will admit the patient and
Please tell me
after taking all the fitnesses, I will
the things have
I
you
will
done. Please tell me how will you do
go
ACL?
for the I will go for the orthoscopic ACL reconstruction.
Okay, good. How do you know the portals for the ACL reconstruction?
Yes, sir. There superior lateral, superior medial, and inferior lateral.
Although time's up, Salman, sorry for this. We will join the next meeting on the links, and I'm sorry for this again, and we'll resume from here.
Okay.
Sorry for this.
So let's join the meeting again, and Salman, I will come back to this. All right.
Okay.
Sorry for this.